comparative study of thoracic epidural analgesia versus intravenous opioids in patients with traumatic multiple fracture ribs. Blunt thoracic trauma is the second most frequent injury found in non-intentional injury-related deaths. Rib fractures as a part of blunt thoracic trauma are very common and have been documented in up to 2/3 of the cases of chest trauma, with mortality under pulmonary complications rates ranging from 3 to 13% and from 16 to 60% respectively. Diagnosis of fractured ribs. Pain when breathing or with movement. A portion of the chest wall moving from the rest of the chest, which is known as flail chest. A grating sound with breathing or movement. Unfortunately, chest X-ray confirmed diagnosis, but 50% of cases are not detected radiographically. Common sites for fractured ribs. Rib fractures typically affect the 5th through the 9th ribs. Also, fractures usually occur from direct blow or from indirect crushing injuries. The weakest part of a rib is just anterior to its angle, but a fracture can occur anywhere. The first rib is rarely fractured because of its protected position behind the clavicle. Pathophysiology of fractured ribs. Pain. Pain makes respiratory effort difficult, increasing the work of breathing and decreasing effective coughing. All this prevents deep inspiration, so tachypnea, hypoventilation, and retention of secretions develops. This deterioration causes hypercapnia, hypoxia, and later on atelectasis, infection, and pneumonia. This chain of events makes accompanying pulmonary contusions and ventilatory deterioration worse, resulting in acute respiratory distress syndrome. So, pain control is one of the most important parts of thoracic trauma management. Complications of fractured ribs. Hemothorax, pneumothorax and tension pneumothorax. Flail chest, which is the most serious complication of blunt thoracic chest wall injury. The incidence of flail segment is 10 to 15% in patients with major chest trauma. Abdominal, organ injury and aortic injury, and finally pulmonary contusions. Management of blunt thoracic trauma. By managing the underlying lung injury and the optimization of mechanics through chest physiotherapy and optimal analgesia. We have two major goals. First is prevention of hypoxia and atelectasis, and the prevention of secondary pulmonary complications and the clearance of secretions. Treatment modalities. It is now generally recognized that pain control, chest physiotherapy, and mobilization are the preferred modes of management of blunt thoracic trauma. Failure of this regimen and starting mechanical ventilation sets the stage for progressive respiratory morbidity and mortality. Treatment modalities. Intravenous narcotics, which the use of a systemic narcotic has a disadvantage, which is tendency to cause sedation, cough suppression, respiratory depression, and hypoxemia, which interfere with the main goal of management of multiple fracture rib, which is now the mainstay of treatment. Epidural narcotics and the local anesthetics, intercostal nerve block, intrapleural analgesia, thoracic paravertebral block. Thoracic epidural analgesia is the gold standard in the management of fractured ribs. Benefits of the epidural route include improving analgesia with longer lasting pain relief and fewer doses and less sedation, early restoration and improvement in pulmonary function, decreasing metabolic stress response, and earlier ambulation. Complication of thoracic epidural analgesia, catheter-related side effects, pain on injection and backache, post-dural puncture headache, epidural abscess or hematoma, neurological complication, which is the most serious complication, but relatively has a very low incidence as published by the American Society of Anesthesiologists, which concluded that the incidence of predicted maximum risk for permanent neurological complication is 0.07%. Total center neurological block. Catheter migration, occlusion and tearing. Epidurally administered drugs, which we will use in thoracic epidural analgesia. Opioids, local anesthetics, clonidine, dexamethasone, magnesium sulfate, ketamine, newstigmine, and tramadol. Opioids. In generally, the side effects of epidural narcotics are not different from those seen with intravenous opioids. Respiratory depression, which is the most serious narcotic-related side effect associated with epidural analgesia. Therefore, a decrease in the patient's level of consciousness or arousability is considered the best indicator for respiratory depression. Pruritus, hypotension and bradycardia, nausea and vomiting, urine retention. Local anesthetic toxicity occurs as a result of excessive dose of local anesthetics in the epidural space, including hypotension, lightheadedness, up to convulsions, coma, and cardiorespiratory arrest may occur. After approval by our institutional ethical committee and obtaining an informed consent, this study was carried out in Tanta University on both sexes from 20 to 40 years old, with patients with multiple fractured ribs and deemed to require intense anesthesia by cardiothoracic surgeon were included in the study. Patients who are excluded from the study: patient with severe cardiovascular disease, severe respiratory, renal, or hepatic disease, patient indicated for mechanical ventilation, patient indicated for immediate surgery for associated injuries or head trauma, patient with hemodynamic instability, and a contraindication to epidural analgesia. We have two groups. Group 1, which is the epidural group. Patients in this group received the epidural analgesia using bupivacaine 0.25% with fentanyl 5 mic per milli in 5 milli solution. Initially, 5 milli of the solution was injected epidurally as a loading dose, followed by 5 milli of the same solution 1 hour later given by syringe pump. Group 2, which is the control group, which was the usual method for analgesia, by receiving intravenous bolus dose of fentanyl, followed by continuous fentanyl infusion. Patients have to be admitted to ICU with the following precaution: oxygenation, monitoring, IV line, physical examination, lab investigations, and imaging. Under strict aseptic precaution, we inserted the catheter at the level of T7, started through the median approach in the sitting position using loss of resistance technique. First, we have to identify the surface landmark by starting counting from C7, which is the most prominent process in the neck, and T7, which corresponds to the inferior angle of the scapula. 5 milli lidocaine, 2% was used as a local anesthetic. The needle stellate was removed, and the sterile syringe with normal saline was attached to the hub of the needle and was advanced using continuous gentle pressure till its tip exits the ligamentum flavum and the saline is easily injected into the epidural space. The syringe was removed and the catheter was threaded gently via the needle into the epidural space. The catheter was fixed to the skin and dressed with sterile occlusive dressing. The following criteria was measured in both groups. VAS, which is a visual analog scale, was measured at rest and during cough, respiratory rate, oxygen saturation, and O2 index. These criteria were measured at the following time: initial assessment, 30 minutes after the start of epidural and intravenous fentanyl, daily for subsequent 4 days. Results. Comparison of VAS, mean values VAS, which is a visual analog scale, which we use to assess the severity of pain. Comparison of VAS means value at rest showed no significant difference between the two groups between before and at 30 minutes after administration. At the end of the first, second, third, and fourth day, the mean values of VAS were significantly lower in the epidural than in the control group. Comparison of pain scoring at cough between both groups showed no significant difference between the two groups before and at 30 minutes after. At the end of the first, second, third, and fourth day, the mean values of VAS were significantly lower in the epidural group than in control group. Comparison of respiratory rate values in both groups showed no significant difference between both groups. ABG's parameters were comparable in both groups. Patient outcomes. There were 6 patients in the control group presented drowsiness and required more close observation and frequent ABG analysis. The need for diclofenac potassium were significantly lower in the epidural group than in the control group. There was no statistically significant difference in other parameters in both groups. It is now clear that epidural administration of narcotic analgesic combinations is highly effective in controlling subjective pain and decreasing rescue analgesia, while there is no significant difference regarding the measured pulmonary parameters. Thank you.